Okay, good evening and welcome to tonight's webinar that's going to focus on pediatric and adolescent scoliosis. As everyone knows, these have been weekly recurring webinars, and next week's will be on back pain with another awesome faculty. We just finished up the hand one on carpal instability. You can watch the replays for all the previous ones at the website below, and next week's will be on carpal fractures and dislocations. So tonight we have an amazing, world-renowned, really star-studded faculty, no pun intended for one of those pictures. We're going to start off our evening talking about the anatomy and physical examination of scoliosis with Greg Mencio from Vanderbilt. We'll move on to imaging for pediatric scoliosis from Rick Schwend, then go on to early onset scoliosis from Dr. Paul Sponsler from Johns Hopkins. Dave Skaggs, our celebrity superstar here, will talk about congenital scoliosis. We'll then go to Sukin Shah, who will talk about adolescent idiopathic scoliosis, and end our evening with Dan Ciccato from Texas Scottish Rite on neuromuscular scoliosis. So again, I want to thank this amazing panel for doing this, and hope everyone enjoys this evening. And I'm going to turn it over to Dr. Mencio.
Hey, thanks. Let me just see if I can get the screen share thing going. And
you are good.
Got that?
Yep.
I can go to presentation view. Perfect. Okay, very good. So that was, hopefully the rest of it will go as well. Well, Josh, thanks so much for including me and all of us. I'm going to try to set the table for the folks that follow, and we'll start by talking anatomy and physical examination of pediatric scoliosis. No disclosure. So what is scoliosis? It's an abnormal lateral curvature of the spine. Prevalence is somewhere between 2 and 3%. This is the thing that I think you need to remember about scoliosis. It's a finding, not a diagnosis. So we need to find an adjective to precede scoliosis. What's normal alignment? The coronal plane is less than 10 degrees, and in the sagittal plane, 55 degrees of kyphosis in thoracic and 60 degrees of lordosis in the lumbar region. Let's see, that's not advancing. Oh, there we go. Regardless of the etiology of the underlying cause, the pathoanatomy is pretty consistent. It's a complex 3D deformity that's characterized by both lateral curvature and vertebral rotation. The specific pathoanatomy involves wedging eventually of the body, the vertebral body into the disc base, as seen here in this Netter drawing. And then, of course, rotation. You know, we tend to view this in 2D, but it's a 3D problem. So there's vertebral rotation, the body rotating towards the convexity of the curve, the spinous process towards the concavity, with rib deformity on the convex side posteriorly, and the contralateral side anteriorly. So we can talk about the different classifications or ways to classify scoliosis. Simplest, is it structural or non-structural? Remember, the minimum Cobb angle for scoliosis is 10 degrees. If it's less than that, it's spinal asymmetry. And then probably the way that we describe it most and talk about it most frequently is in terms of etiology, congenital, which we'll not be talking about tonight, idiopathic, and neuromuscular. Again, remembering that scoliosis is a finding, not a diagnosis. We can classify further by age at onset. So infantile, juvenile have sort of become lumped into this early onset group. Adolescent up to 18 years, and then adult or de novo onset degenerative scoliosis we see in adults, which is not part of really what we do. And then the other thing to think about is when you're describing an X-ray, or is what's the anatomic location, and this is from the SRS lexicon. Cervical thoracic, it's C7T1, thoracic and apex T1 to 11, thoracolumbar specific T12 to L1, lumbar below that, and lumbosacral at the L5S1 junction. This will be talked about later, and we can classify further idiopathic using the Lenke classification, which has become widely accepted, and the classification system that exists now also for early onset scoliosis that includes both congenital and structural and neuromuscular. The key component here is age onset and less than 10. And then in the neuromuscular group, we can classify based on the type of abnormal muscle activity. Is it upper motor neuron? Is it lower motor neuron? Is it primary myopathy? And also by per type, the type 1s, which don't involve pelvic obliquity, and the type 2s, which do involve pelvic obliquity. So in terms of evaluation, we need to do a consistent history, who referred the patient and why. Remember that back pain is present in up to 30% of kids with scoliosis, and there's only identifiable source in about 10%. Need also to be questioning about headaches, neck pain, weakness, any sort of ataxia or neurologic symptoms, which may be a clue to some underlying neuropathology. Obviously for girls, menstrual history, and then because of the genetic component, is there a family history? Just a quick comment on school screening, because this is the way some of these kids still get in our system. The pros are that it allows for early diagnosis of press brace treatment. The cons, it's not cost effective, and the U.S. Protective Services Task Force came out with a statement that says there's insufficient evidence to assess benefits and harms, but we still do in about, it's actually legislated in about 23 states, ours not being one of them. And this is what the screeners look for. They're looking for the angle of trunk inclination or rotation of greater than 5 degrees is their cue for referral. A lot of these kids come from sports screening exams. In the neuromuscular population, remember there's a specific etiology, and I'm sure this will be talked about later. We need to know, again, is it upper versus motor? What's the ambulatory status? And what's the condition of the pelvis, hips, and lower extremities? In terms of the physical exam, this needs to be done with a shirt off boys and some sort of an open back top for the females. And we want to assess standing, bending, and don't forget sagittal plane. For the neuromuscular group, this is likely going to be a sitting exam, looking for pelvic obliquity. Remember the problems with the hips, and then also how the lower extremity spasticity or contractures may impact sagittal plane or other alignment. So shoulder height shown here, to assess pelvic height or obliquity by simply looking at the iliac crest. Scapular symmetry, which will be impacted by thoracic curves and any rotation. Trunk shift by the C7 plumb line. Arm flank asymmetry, another way to sort of look at trunkal balance. And then, of course, the Adams forward bend test, which is what the screeners use and which you can do by eyeball, and it measures angle of trunk inclination at the apex. A different patient, again, showing how you should look at it from the back and also from the side. Remember the importance of checking for cutaneous stigmata, midline defects, palpate for those, patches, sinuses, hemangiomas, cafe au lait spots. This was the finding in this patient with that midline hairy patch. Remember also to check for signs of ligamentous laxity as a sign of perhaps collagen-based disorders. This is a classic test for arachnodactyly, showing the thumb and palm sign. Basically, when you fist the thumb, you should not be able to see the end of the finger as shown on the right. And I just want to go back. And then the wrist sign, which is basically the ability or the inability to touch your thumb and tip of little finger at the wrist, except in an abnormal situation, which again shown on the right there. So neuro exam, motor, remember to do deep tendon reflexes, patellar tendon checks for L2, 3, 4, Achilles, S1, S2. Remember also abdominal reflexes, T8, T9, T10 by the, is above the umbilicus, and T10, T11, T12 reflected by the findings below the umbilicus. This is done by stroking away from the umbilicus in each of the quadrants. And remember that unilateral absence is a more significant finding than absence between the upper and lower quadrants. And finally, you need to assess the feet. Look at the feet. Take the shoes off. Always do this. You want to, you know, and if you see a cavus foot, be thinking about other stuff. And in this case, in an MRI, and in this case, this person had a lipomeningocele. So that's what I have for anatomy and evaluation. I think imaging considerations are next, and I'm going to, I guess, pass on to Dr. Rick Schwend. So thank you very much.
Great. Thank you very much, Greg. So we'll move on to imaging for scoliosis from Dr. Rick Schwend from Kansas City. If you could just hit stop share, Greg.
Yep. Yep.
Perfect.
Okay.
Let me see if I get this to presentation. All right, can you see that?
Yep. You just
okay.
Perfect.
Good. All right, we're going to talk about imaging and pediatric scoliosis. I have no disclosure relevant to this talk other than we're still Super Bowl champions. Oh. All right, so these are the learning objectives. I'm going to talk about radiology basics, safety, and common pitfalls to avoid. Here's some of the basics. Really what you want is, in any radiograph, you want two views, and likewise, you need to have an open mind to see two sides to any clinical presentation if you want to see things correct. As far as the basics, the SRS manual is still really useful, especially for research. It does show things like the proper stance for imaging. Traction films are very useful for large curves and neuromuscular curves. Regarding screening, the four societies have come up with screening recommendations. Essentially, girls at age 10, girls at age 12, boys at age 13 or 14. But really, the essence of screening is a scoliometer, not radiographs. And then radiographs are used when the results of your screening are abnormal and you're looking at more defined imaging. We're going to talk about radiation safety now. Minimizing radiation in a nutshell. Use a clinical examination and a scoliometer. And then think about image number in terms of minimal number of visits and films. And then in terms of image quality, in terms of work with your radiology department to image gently. Well, what is image gently? It's really using the principles of ALARA, which is as low as reasonably achievable. And so that should be your overriding theme, pediatric radiologists, to cut down on radiation dosing. But what is the normal background radiation? It's about 3 millisieverts a year. You can't avoid this unless you live up in Colorado, and it's even worse. It's about twice that of living at sea level. What are some of the concerns about radiation exposure? Well, the big one is that children are about 10 times more sensitive to radiation than adults. And so the best way to decrease CT dosing, not order it or delay it as much as possible. And then there's things like EOS imaging. Can that decrease radiation exposure? Well, this felt to be at least about 1/8 as much radiation as plain radiographs. And the effect of cumulative dose in treating a scoliosis can, in theory, be about the exposure of one environmental exposure per year. So that's pretty reasonable radiation dosing for treatment of scoliosis. What is the benefit of PA versus an AP film? Well, there again, the PA film gives you much less radiation than the AP film, especially to the breast and thyroid, and especially in girls. Advantages of a scoliometer. You should always examine and record the scoliometer measurement of the spine. It can detect early progression that a radiograph may not. So I find that this is a very useful tool in association with your radiographs. So what does this all mean? Well, in terms of quality, we should use the higher dose of EOS imaging for the initial imaging, and then lesser doses for follow-up evaluation. In terms of quantity, less frequent visits means less frequent radiographs. Use your scoliometer and do clinical follow-up evaluations as much as you can. I'm going to get into a little bit of some of the pitfalls that I've learned over the course of my career. These are some of them. I'll go into specifics a little bit on these. One of them is accepting poor quality imaging. This is an example of a T1 to T2 spondylosis that was missed on the AP and lateral radiographs. And one of the pitfalls is that the third cervical thoracic junction is a difficult area to image, and major deformities and fractures can be missed. So pay attention to this area. Sometimes you do need advanced imaging in this area. Abnormal number of vertebrae, those are often easy to miss. Be careful about the numbering. You may have 11 thoracic or 6 lumbar. You have 13 thoracic and 4 lumbar. Misclassification scoliosis. This is a standard classification for scoliosis, 4 parts, but sometimes the classification can change. A study of early onset scoliosis found that 4% had an abnormal MRI, and so a lot of these idiopathies become reclassified into neuromuscular. This example of an 11-year-old girl with congenital scoliosis, urinary incontinence. She had an atypical curve, but an MRI showed that she also had a syrinx and a lipomeningeal. So this congenital scoliosis was also, in fact, neuromuscular. Not evaluating the 3D nature of the spine. So remember the transverse and sagittal planes. So this transverse plane is important. This is the sagittal plane. So here's when you bend forward, you can see how extreme the the transverse plane is. And we have advanced imaging now with EOS and other techniques to look at the transverse plane more carefully. But in terms of sagittal plane, it's really your clinical evaluation to look at the actual patient's clinical observation. When they bend forward, do they still look flat? On the plane radiographs, this girl is very lordotic, and it showed up in her pulmonary function studies with a vital capacity of 47% and air compression. This patient came to us with having had surgery somewhere, and they fixed the coronal plane, but they didn't pay attention to the sagittal plane, and so this patient still had cervical kyphosis. The thoracic spine was not adequately corrected. It required multiple Smith-Peterson osteotomies to get the correction just right. So pay attention to the sagittal plane, and also sagittal plane balance starts with pelvic balance. So always start there and look at your pelvic parameters. Underlying bone lesions can cause problems. This 13-year-old boy with night pain and stiffness had an atypical curve. Plain radiographs looked okay, and the MRI was read as normal when it was done, but the bone scan was positive. And when we went back and did a CT scan, you could see there was an osteoma on the 12th rib. And then going back to the plain radiographs, you could actually see this thing was there all along. So review yourself before ordering advanced imaging. And then underlying soft tissue lesions can cause problems too. This 9-year-old boy with atypical scoliosis had a normal neurological exam and had a, quotes, normal MRI from outside. When we were actually doing this anterior release, you could see this large ganglion neuroma noted during anterior exposure. And then finally did get a chance to find the MRI. It showed this large lesion that was just misdiagnosed, had a ganglion neuroma coming off the spine. So the lesson learned is don't trust outside normal MRI reports. And then we went back and looked at the plain film to see this retropleural soft tissue mass was there all along. And then finally, not using advanced imaging to your advantage, this 12-year-old boy with congenital scoliosis, neurologically intact, when we were doing his surgery loss of intraoperative monitoring during the anterior release. And when we went back and looked at his MRI, you could see his spinal cord normal lower down his lumbar spine, but as you advance closer to the apex, you could see the spinal cord getting more and more compressed up against the pedicles. And in this view, it's squished and there's no fluid around it. And this brings up this new classification for the spinal cord, where type 1 has fluid around it. Type 2 is up against the pedicle, and type 3 is squished. And if I had just read that article, I would have avoided that problem. And type 3s had a 28 odds ratio of intraoperative monitoring alerts. So in summary, image gently, consider HALARA, minimize the quantity of films, especially CT, maximize the quality of your technique and films, accurate classification and diagnosis, and avoid the common pitfalls that I just discussed. Thank you very much.
Great. Thanks very much, Rick, for finishing us off on setting the stage. So we're going to move into some of the broad categories of scoliosis and move to Paul Sponsler from Johns Hopkins, who's going to talk to us about early onset scoliosis. I think you're on mute, Paul.
How do you work it up?
Oh, there you go.
Conservative and operative treatment. And throughout this presentation, that red box is a common test question, so pay special attention to that. So the terms used vary a little bit. In the older days, you'd hear the terms early onset, that is infantile and juvenile scoliosis, but recently those were lumped together to simplify things by Dave Skaggs and Baruz and the Growing Spine Committee. So I think that combines both infantile and juvenile, anything under age 10, because they have certain features in common. Why is the distinction? They have different presentations and different behavior. For instance, presenting, they may overlap with syrinx and they may overlap with syndromes that may not be diagnosed yet. In the infantile group, especially, males actually predominate as opposed to females we're more used to. The thorax more often goes to the left apex in the early onsets, and they have differing behavior. They can either be really benign or they can be really malignant. Some early onsets will resolve spontaneously, but others will increase severely and cause premature mortality compared to what's expected for the age. And really what we're dealing with is growing the whole torso, the trunk, the chest cavity, because the thorax is the dimension of the spine. And that's what we're really trying to preserve in these early onset curves. Another reason for the distinction is that the goals are different. We're trying to grow the spine while correcting it and maintaining some degree of flexibility. Many surgeries often, so we're trying to minimize those. And we're trying to prevent iatrogenic deformity and get the thoracic spine from T1 to T12 to be approximately 22 centimeters. That's kind of a goal for a relatively viable pulmonary function. So the workup should include a dedicated MRI for both infantile and juvenile. Anybody in the early onset group should have an MRI because you're trying to rule out the kind of baseline levels of syrinx, Chiaris, and tethers. This patient shown here on the right has a huge syrinx due to a Chiari, but he was neurologically normal. This patient shown here on the left had what looked like an infantile idiopathic curve. He had this really unusual cervical thoracic kyphosis as well. So you'll find a lot of positives if you image these kids, and certainly before you do any intervention, it's appropriate to get an MRI. That's a standard of care. So observation is indicated for some of these because not all will progress. The parents come in worried that their kids are going to eventually need surgery, but Dan Zaccato has shown that some factors are actually favorable. The earlier the onset, the more likely it is to self-resolve. If a Cobb angle is less than 30, it may actually not worsen. If the ribs are not rotated or the rib vertebral angle difference, which we'll talk about, is less than 20, they may not get worse, so it's worth watching those under 30-degree curves for a bit. The rib vertebral angle difference is the best predictor of progression, and that was really developed before we had 3D imaging modalities by Min Mehta, and it's basically taking the apical vertebra, measuring the angle of the ribs on the convex versus the concave side, and subtracting them. So here, 45 degrees minus 15 degrees equals 30, so that's more than 20, so that means this patient's probably going to progress and should be treated. In this case, we would use a metacast followed by a brace. Metacasting has really been a game changer. Just like Ponseti casting for clubfoot, it took a while to catch on, but some enthusiastic proponents like Jim Sanders and Jacques Dastu have shown that this can be done. It can produce amazing and very satisfying results. And know we all enjoy operating, but it's even more satisfying to see something like this. This kid had a curve that seems like it would not get worse on its own, or better on its own. So metacasting left him with a straight spine. You can see a little bit of rotation, but certainly a lot better. So the indications for casting are bob greater than about 30 to 40 degrees, RVAD greater than 20, ribs that overlap the vertebral body, and there's really no clear upper cob limit. And some people have had successful results even up to 70 degrees, although certainly that's worrisome. The casting can be done on a specialized table called a metatable, or even on a spica table. In San Diego, they do it in a sideways fashion like a banana. And the cast should be left on for months, and it's changed at a frequency depending on the age. So for a kid under 3, you can change it about every 2 months, under age 4, every 3 months, and so on and so forth. And you stop casting when the cob is less than 10 degrees or plateaus, and change them to a full-time brace. The results have recently been published by Graham Fedoruk and the Utah group in a recent JBS article, showing that if you define a cure as a cob going down to 15 degrees at final follow-up, over 50% of idiopathics were cured, although 5% did later relapse. But that's still a pretty good rate of improvement, and the others were officially delayed. The things that predicted a higher rate of cure were a lower initial cob, a flexible curve that corrects to 25 in traction, or gets a lower RVAD in traction. So here's an example of one of my patients with a double curve. It was metacasted and then braced. And here he is at age 15, not yet done growing, but still, I think, in pretty good shape, hopefully, for the future. Juvenile scoliosis, that is 3 to 10, also needs to have an MRI because he will also pick up a higher frequency of syrinx or Chiari than you would in the idiopathic adolescent group. For the juveniles, however, they're less likely to accommodate to a cast. We will offer it to some of the younger ones, but generally most of these are braced if they're greater than 20 to 25 degrees. It requires a skilled orthotist and dedicated family to really make this work. And only a few of them actually really succeed to maturity. About 50% of them will need surgery, which is a higher statistic than you would see for adolescents. Surgery for early onset scoliosis is a patient who's either kind of a poor brace or cast candidate to start with or fail brace or cast treatment. I will often let these curves get up to 70 or 75 degrees if they're very young before making the decision to go to surgery. And the surgery is typically a growing rod if they're young of some kind, either surgeon directed or magnetic, or a self-sliding rod, or if they're close to juvenile adolescent threshold, you may go straight to a spinal fusion. The idea of a dual growing rod was really a game changer, and it has stable proximal and distal foundations with either hooks or screws, and it's lengthened every 6 to 12 months, or now we have magnetically powered options, and we even have some more rarely used self-sliding options. And these are usually done as long as possible and sometimes finally fused at maturity. A little bit about the magnetic technology. These allow non-operative distraction, but they don't work for everybody. Spine is too stiff, such as a reoperation, or the patient's obese with more than 3 centimeters from the skin to the spine, probably will not really power to distract the spine. So they're good for the really younger kids or the first few years. Don't always work as well as we sometimes hope. An important concept on timing is that these patients get stiff if they're instrumented for too long. The spine auto-stiffens or auto-ankyloses, and we call that the law of diminishing returns. Actually, Dave coined that term, and it's shown here by the number of distractions getting less and less length each time, and what seems to be happening is the spine is stiffening. So the rule of thumb is to defer the start of growing surgery, if possible, till about 6 or 7, so that you can get that 5 or 6 years before returns diminish. On the other hand, I don't want to let the curve get more than 80 degrees because the risks go up. And if the patient is getting toward teenage years, like if they're not 10 or 11, it's probably not worth starting this growing treatment. Just wait a bit and go definitive fusion. Also, in some of the neuromuscular patients that are higher risk, such as CP and Milos, probably be wary of that infection rate, and you may not want to do the growing treatment at all. For growing treatments, the most common levels in an idiopathic-like patient are 2 or 3 levels of anchors proximally and 2 distally. For a neuromuscular patient, we go more distal. So usually it's T3 to L3 or L4, as shown here. At the end of the actively growing treatment, you can either do a final fusion or even let them stiffen in place, called no final fusion, which is an option for patients who are in good shape and getting stiff and haven't broken their rods in a while. And this is a patient who had old-fashioned growing rods and never had a final fusion and is now into his 20s. Early onset scoliosis surgery has more complications. About 25% or more of patients will have some complication during their treatment. That's either an infection, as you can imagine from the multiple surgeries, or some kind of growth-related deformity, PJK, DJK adding on, or a neurologic deficit. So in summary, remember to get MRI for these patients and possibly genetics to rule out syndromes. The goal is to grow the spine and chest wall, so delay and prolong the growth as much as possible. Remember that CAD can actually cure or meaningfully delay the progression, and bracing also has a role. And try to avoid fusions before the height velocity of about 10 to 12. Thank you.
Awesome. Thanks very much, Spani. We're going to move to some congenital conditions to supplement that talk from Dave Skaggs on the West Coast out in LA. Thanks, Dave, for joining us.
Okay, could you see my screen?
Yes, you're set.
Okay, congenital scoliosis in 7 minutes. So congenital scoliosis occurs at 6 weeks in utero. So this happens before babies are born. Sometimes new residents call any type of early onset scoliosis congenital. It's not really correct. It's something that was when the baby was born. There's 3 main types. One is a failure of formation, which is a hemivertebrae. The hemivertebrae could be fully segmented with 2 discs in between, not segmented at all, or semi-segmented. The next general classification is a failure of segmentation. There could be a unilateral bar, or if it's a bilateral bar, it's called a block vertebrae. And most are mixed. There seems to be a combination of some hemivertebrae, could be multiple, and some of the vertebrae could have bars. So the majority of the time, there's some associated anomaly in congenital scoliosis. So from real life and test taking, is you hear congenital scoliosis, think what else is going on. One, there's about a 20% incidence of cardiac problems, so order an echocardiogram. There's no downside to doing that, even in the older kid, if it hasn't been done before. About 20% renal abnormalities. Should we get the ultrasound? In the old days, we always did, but now that you even let kids play football with a kidney, maybe it's not indicated. Not really sure here. And MRI is indicated anytime before surgery is done, or anytime there's significant progression, especially outside of the congenital area, because depending on the series, 20 to 40% of the time, there's a neural axis problem. A special type of congenital scoliosis is Charcot-Levin syndrome, in which there's multiple rib fusions and multiple anomalies of the thoracic spine. These kids often have thoracic insufficiency syndrome, and the thoracic spine is often about the same length as the lumbar spine. So this is a classic test question. Bracing not indicated for congenital scoliosis. Now in real life, sometimes people brace the non-congenital part of the curve, but this is the test answer. Let's talk about a few special cases that tend to get tested frequently. First, an L5 hemivertebrae. Now there's not spine below that to compensate, so a hemivertebrae at L5 tends to tilt the patient off to the side. So the answer is resect a vertebrae at L5. Here's a case in which the L5 hemivertebrae was not resected, and you can see how the patient is decompensated off to the side. This is a poor example. Don't do this. The head should be resected. Now, another special case is when you have high cervical congenital anomalies. They're very hard to see on x-rays sometimes, and because there's no spine above to compensate, this could lead to significant head tilt, oftentimes best seen on a CT scan and could involve the occiput itself. So this is a classic test question. If there is a hemivertebrae opposite a unilateral bar, the correct answer is immediate fusion. Now, you're going to really be using a one-day-old? Probably not. But in reality, if you can at least put some screws across the convex side of this, of the growth potential, you're probably going to prevent this from getting much worse and saving a much larger surgery for the patient. Now, in cases when you do a hemivertebrectomy, which is indicated for progressive or large deformity, we generally wait until the kids are at least 3 years old, so the bones are strong enough so the anchors don't plow through. You don't want them to be too old because then the whole spine gets too stiff and doesn't crack as much. Generally, we do this posterior only now. It's really rather safe because the spinal cord is the concavity and we're mostly operating in the convexity. Consider fixed angle screws that are less prominent. Consider using long screws as we want to stop the anterior growth as well as the posterior. Resect a rib when you take out the hemivertebrae and consider putting hooks either on ribs or on lamina above and below to close down the empty triangular space and take some of the pressure off the pedicle screws to prevent screw plow. 3D CTs are not only helpful, but in my mind, essential before you go into surgery. You'd be surprised how many times you pick up things on 3D CTs that you might not have otherwise, such as here, you could see lamina defects. You don't want the first time you find this to be with a hot bovie. That could be a bad day. You want to plan for it ahead of time. Now, what about complex cases with multiple anomalies? You could have many vertebrae opposite a unilateral bar. You could do a heroic resection with quite significant risks. When a growing child, we could consider growing rods with distraction over time. It's not going to make the spine perfect, but it will lead to often a cosmetically acceptable result. Now, when you have these mixed pictures, as we often do, it's hard to know when to do surgery, when not to do surgery. I typically use about the same angle indications as idiopathics, or if there's a lot of rotation or other problems or sagittal problems, it might push you towards early surgery. But beware, even though you think this should have been the end of the surgery, the patient did end up having a much more significant curve and needed surgery. Now why am I not moving anymore? So when is surgery indicated? It's hard to tell. One trick you could do is just put your hand over the anomalous region, and if the spine looks pretty straight above and below, you're probably okay. Now another special case, cervical thoracic. When there's cervical thoracic, it causes a head tilt, which could cause much more significant cosmetic deformity than you might otherwise expect from the Cobb angle. Same principle, stop the growth on the side that's growing too much, maybe do a little bit of distraction on the other side. It's much safer than doing a heroic resection of multiple vertebrae, and will have acceptable cosmetic results, frequently, not always. And the last special case here is Klippel-Feil syndrome. It's defined as 2 or more fused cervical vertebrae. The classic triad of limited range of motion, low posterior hairline, and a short web is only present less than half the time. You should know this. This is a frequent source of test questions. So when kids have Klippel-Feil, think that they have other congenital scoliosis, Sprengel's deformity, Renal's disease, or deafness. That comes up on a lot of test questions. And it's okay to participate in sports if they only have 1 or 2 levels fused below C3. If you have a fusion at C2 and above, no collision sports, no contact sports. And last topic is congenital kyphosis. The natural history can be paralysis if this is progressive. If you're lucky, you catch this early, you can do a posterior only fusion for less than 50 degrees of kyphosis in a patient less than 5 years of age, and it should grow straighter over time. If it gets to this point, it's a very high nerve and generally some type of an anterior resection is needed, whether you're doing it from the back or the front. And lastly, if you have cases of congenital kyphosis, we know that there's a high incidence of losing neuromonitoring signals, neurological problems. One may want to consider the possibility of doing a slightly longer fusion with multiple pontiodectomies. Thank you.
Awesome. Thanks, Dave, very much. So we're going to move on to the more common adolescent idiopathic scoliosis with Sukin Shah from DuPont.
Great, thanks, Josh. Are we all good? Everyone see it?
Yep,
Yep.
you're good.
So this is our common scenario. We see a 1-year-old girl come into the office with a 20-degree curve. The parents and family are distraught. What happens next? And we have to act like a fortune teller and try and figure out what this curve is going to do. Well, the thing is, prognosis is a central issue in AIS care because the vast majority of those small curves won't go anywhere. We're going to worry people. We're going to x-ray them unnecessarily. We have to find the small percentage of curves that are going to progress, perhaps intervene before they go on to surgery. Prognostication in AIS is a complicated topic. We'll only have time to touch on a few of these items here. What we have to recognize that it's a three-dimensional deformity. And I want you to understand that the essential lesion is apical lordosis. At the apex of the curve, the spine is curved backward. This leads to dorsal shear stresses and remodeling and a vicious cycle of a continuous set of events that makes the spine more curved. The curves will progress most often during peak height velocity right before puberty. And it causes bone remodeling, which can secondarily be more contributing to the spinal deformity. What we also have to realize is that because scoliosis is a disorder of growth, we need a really accurate way to assess skeletal maturity in the clinic very quickly, without blood tests, without spit tests, looking at x-rays that we find. A long time ago, Lonstein and Carlson looked at the age of the patient and the curve that they presented with, and basically showed us if you were young and showed up with a large curve, you were going to more often progress. But that's not good enough now because we need to customize treatment. The Risser sign or the iliac apophysis was used for a long time. This ossifies lateral to medial as you get older and as growth decelerates. But we know there are many problems with this. Parallax X-ray, boys hang out at Risser 4 for a long time, and it's not very accurate. 12 and 13 years ago, Jim Sanders came with this seminal literature showing us that the hand X-ray is a much better predictor of skeletal growth and came up with a very simple way to provide an algorithm to how we can predict progression. If you look at this table, you'll see that the Tanner-Whitehouse RUS score or the hand X-ray is really, in fact, the most reliable way to assess maturity. Chronologic age and timing to heat velocity aren't actually bad, but look how far down on the scale Risser stage actually is. This is the key stage to identify. When you look at a hand X-ray and the epiphysis is wider than the metaphysis and it actually caps over like a beret, that's the curve acceleration phase, that's the patient's peak height velocity, and that's when the curve is going to progress. Another important stage is 7, when all of the epiphyses are closed and the patient's spine growth is essentially done. This is when we typically brace, and this is when they're sort of out of the woods as long as their curve isn't over 40 degrees. We duplicated Sanders' work with 8 times as many patients and found these statistics to be quite valid. You can basically take their Sanders stage and their Cobb angle and figure out what their risk of progression is. I find this to be very helpful in counseling, especially for those brace patients who may not have the best compliance. Currently, the state-of-the-art is Stéphane Perrant's work in Montreal. Here, they're looking at 3D progression factors for risk of progression. And they're looking at 6 different categories of measurement, looking at the 3D EOS imaging, looking at the angle of curvature, at the wedging, not only of the bone, but of the disc, and also the torsion and the slenderness of those vertebrae. It's been very accurate. And just looking at the first film is about an R-squared value of 5%. The second film is an R-squared value of 0.7%. Essentially, we know the future rests in genetics. The problem is this is a complex genetic disorder. It means it has high prevalence, extreme variability, maybe some environmental factors. And we don't even know if there's a specific mode of inheritance. But there's work continuing in various different centers, in various different ethnicities and races. And when we have an animal model, like the zebrafish that is maturing, we'll understand this a little bit better. But what I'm getting at is that we can take big data, we can take genetics, we can take these parameters, put it all together in AI, and actually provide our patients with customized treatment, observation, bracing, and surgery. So the current SRS guidelines for AIS management are the following. Clinical observation is indicated for small curves and patients who have skeletal immaturity. You can follow them with serial x-rays and exams and they're out of the woods. With a curve of less than 30 degrees of skeletal maturity, they have virtually no risk of having a problem as an adult. Moderate curves we can treat with bracing. These are curves between 25 and 40 degrees, and if they have continued growth, you should follow them, brace them if necessary. And finally, operative treatment for those curves greater than 45 or 50 degrees. People with curves greater than 50 degrees, even if they're done growing, have a potential to progress during adulthood. This can affect their quality of life and their choice of different situations. There are various bracing modalities available. The Milwaukee brace is no longer in favor. Most of us would treat patients now with what's called a TLSO, underneath the arms, thoracolumbrosacral orthosis. The most popular is the Boston. We use the Wilmington. The way these braces work is by soft tissue shaping with 3 or 4 bending, trying to derotate and translate the spine and effectively push the ribs over at the apex of the curves. Normally, these are well tolerated in thin patients with flexible curves. Why do braces work? Well, there was a lot of controversy about this. Stu Weinstein's seminal work in the New England Journal of Medicine. He designed a brilliant study, which I think every person on this call is a co-investigator, of multiple centers, skeletally mature patients with curves between 25 and 40 degrees. There was a randomization arm and then a selection arm. They were given a rigid TLSO for 18 hours a day, with the primary outcome being if you were done growing or went on to surgery. The study was stopped early because the findings were so overwhelming in favor of bracing. You can see here from the intent to treat analysis that bracing was 75% effective in those candidates who were at risk of progression. If you didn't get a brace, you were only 42% effective at avoiding surgery. The other really interesting finding was there's a dose-dependent response to bracing. The more you wear it, the better it works. Bracing stopped, most of us would say postmenarchal for 18 months, 2 visits that there's no growth achieved, standard stage 7 plus Risser stage 4. There is some equipoise in this area, but you can't wean the brace too early, and we go to nighttime after time. But sometimes bracing fails and operative treatment is indicated. What about the new therapies of scoliosis-specific exercises or Schroth? There is something here. I wouldn't say that we can throw the baby out with the bathwater. We need better evidence here. But when Schroth therapy is combined with bracing, there seems to be a statistically significant effect in terms of avoiding surgery and avoiding progression. So if you have access to this therapy, I urge you to investigate it. What happens when the curve is too big for bracing or the curve has failed bracing? This is a girl with a main thoracic curve. You can see as the curve gets more severe, there's much lordosis at the apex, there's a trunk shift, there's a rib prominence. What do? Well, we obtain radiographs. We try and classify the curve. This is a main thoracic curve with compensatory proximal thoracic and lumbar curves. We get bending films to see which curves are rigid and structural or which curves are compensatory. And then we classify this curve according to the Lenke classification, which describes 6 different curve types, looking also at the lumbar modifiers and the sagittal view or the kyphosis, because kyphosis means you need a fusion. We also think of many different parameters to look at besides just those 2-dimensional parameters. We're looking much more at the 3D, we're looking much more at pelvic incidence and how much thoracic kyphosis to restore. We're looking at which ones are the end vertebrae, which ones are more rotated, and finally put it all together and try to achieve a 3D correction of that deformity with surgery. And you can see here with pre and post-op 3D assessments that we've done an excellent job of correcting the deformity in all 3 planes. The coronal plane is straight, the sagittal plane is more physiologic, and the axial plane is completely derotated. I want you to pay attention to this patient who is a 14-year-old male with idiopathic scoliosis. He has apical lordosis. This is a very challenging deformity to treat with an all-posterior construct. And we know already from Peter Newton's work that the more significant the deformity, the more inaccurate that 2D X-ray is. Many of these patients are much more lordotic than we think they are. And when you derotate the spine, you find that essential lesion there virtually every time in thoracic scoliosis. They're very lordotic. How do we take care of these deformities? And why does it even matter? Because thoracic kyphosis drives lumbar lordosis. It also drives the cervical arrangement. It's also pre-programmed with pelvic incidence and may have significant features with regard to pulmonary function. We can use differential rod contouring to correct these deformities, special screws where we can titrate the kyphosis. And we've also shown that pontiociotomies are very important in a posterior release, allowing posterior distraction. And I know that some of my fellow speakers have some controversy in this area, but it is the best way to perform a 3D correction of the spine when you detether the posterior elements and allow that to be restored back into the posterior column. This is what the spine should look like prior to implantation so that you're achieving very little stress bone screw interface. And the final fusion and derotation and correction should have these screws pointing towards each other with the processes virtually derotated and the rib hump gone. Illustratively, we can take you through the correction. This is an apical lordotic patient with the screws and the releases already done. We translate the curve towards midline. We implant the second rod with a little bit less kyphosis. We derotate the spine. And then finally, with very good monitoring, we can do post-distraction to restore length back into the posterior column. So you get a three-dimensional correction. Those were the 2D. Here's the same patient in 3D with that true lateral, meaning all those apical vertebrae were derotated. Look at how much kyphosis need to be restored, and we were able to do that with an all posterior correction and instrumentation. It was all about fusion, but can we avoid doing a fusion? What's missing here? The holy grail of deformity surgery is trying to correct a deformity without a fusion. Well, we understand 3D spinal growth. We're trying to work out what happens to the discs, and we do have an accurate prediction of who's going to actually progress. What about going back to the anterior approach? That's where the money is. Well, there's a procedure called vertebral body tethering. It's FDA approved only for humanitarian device exemption. And I urge you to proceed with caution. But you can see some really impressive results. If a patient's still growing, the deformity will slowly correct over time. This involves a minimally invasive approach through a thoracoscopic insertion in thoracic scoliosis, of vertebral body screws, and a flexible tether, which will allow continued correction with growth. And these are thoracoscopic views where we visualize the spine with partial lung collapse, incising the pleura, putting in staples to anchor those screws, putting in screws, lining them up with fluoroscopy, and then installing a flexible tether, and then tensioning that on the convex side to show the convexity and allow the concavity to spring up and start growing again. And this is how it can be done with just a few small incisions on the side of the chest. Who are the indications, or who are the patients? Patients with moderate curves, skeletal immaturity present, and I prefer Sanders 3 and 4, that really explosive growth still yet to come, and certainly flexibility of the spine. Those that have failed bracing are also good candidates. But I urge you to proceed with caution, because a look back at the midterm experience of Peter Newton shows that there's good initial correction, but inconsistent midterm outcomes. And many of these patients needed repeat surgeries. So in summary, I would urge you to look at the three-dimensional aspects of scoliosis and look for that accentuation of lordosis at the apex. Spinal flexibility is the key to 3D correction. And I would urge you to look at different fascectomies and osteotomies to make that spine more flexible. Pay attention to rod mechanics and rod contouring. Try and increase kyphosis whenever possible in those patients who need it the most. Look at your 3D correction as your report card to a job of how you're doing. And non-fusion technology is here, but needs further study. So right now, we've addressed those growth assessments, recognizing the sagittal plane, looking at the power of pedicle screws for correction, and the safety that's come with different technologies. But look at the other dimension of scoliosis care. It's very expensive surgery. We need quality and value. And we're looking at pain management, rapid recovery, decreasing the length of stay, and decreasing the cost, which I think is the next avenue in AIS treatment for the future. Thank you.
Thank you very much, Sukin, and a double thank you for putting in commentary and pictures of hands in the scoliosis webinar. So we're going to end this evening with Dan Ciccato talking about neuromuscular scoliosis.
Thanks, Josh. Can you hear me?
Yep, you're good.
Okay, so my task is to talk. Okay, so this is a classification. I think Greg Mencio talked a little bit about this. So we're going to talk about the neuropathic and the myopathic and really focus on CP because it's the most common type of neuromuscular scoliosis we see. So Neuromuscular spine deformity is very different than what Sue spoke of, which is idiopathic, in that there's impaired or abnormal spinal balance, muscle tone, bladder function, GI tract is not normal, pulmonary function is often diminished, the bone quality is often less dense than normal bone, and then oftentimes we have skin or soft tissue coverage like myelomeningocele. So I'm going to talk about general principles. So non-operative management for neuromuscular scoliosis. Bracing is not really effective typically. We use wheelchair modifications and it functions similar to a brace. And then operative management, fusion is long and distally, often to the pelvis. We'll talk about that. Proximally, it's most often to T2. So if you say T2 to the pelvis for neuromuscular spine, generally you're going to be correct and it's going to work out well. The preoperative assessment, absolutely critical. Multidisciplinary team will review a little bit of that. And then really the big issue with neuromuscular scoliosis or deformity is really avoiding complications. Respiratory early infection is really the big one. And then there's certainly blood loss issues that we take into consideration. This is sort of a nice schematic to sort of talk about the big issues that are related to neuromuscular scoliosis, some of the sort of solutions or possible issues that come up, and then some of the solutions. We're going to try to talk a little bit about all of these. It's difficult to talk about them all in 10 minutes. So what about the patient assessment? The nutritional status is really important. And so CP patients, for example, are often thin and have difficulty in terms of nutrition, especially when they have spine deformities. When you have a big spine deformity, you're using a lot of, you have a high metabolic rate, you're oftentimes thin. More important than the size of the patient and their weight is really their nutritional protein and albumin, magnesium, zinc. All those are really important to heal and to have a successful surgical procedure without infection. Sitting balance is really important. Management of the wheelchair, determining progression of the curve, flexibility. Always look at the hips. This was mentioned earlier. Contractures in the sagittal plane and the coronal plane are critically important. If somebody has hyperlordosis, they most often in the neuromuscular area will have a hip flexion contraction that has to be taken into consideration. So a good physical exam, a really thoughtful to these patients is important. What about non-operative management? The principles, and again, we're talking principally about CP, sit comfortably to perform activities, school, and transportation. So if they're sitting comfortably, then they can be treated non-operatively. Maintain coronal and sagittal balance in the wheelchair, and again, working with your occupational therapist is important, and limit curve compression. Using their side rest and reclining position is often important. So here's a very well molded chair for a patient with cerebral palsy. You can see the side rests are positioned appropriately. The reclining wheelchair is also very important for a lot of things, including taking some stress off the spine. What are the surgical indications? The surgical indications are a little bit more difficult and a little bit dispersed compared to idiopathic scoliosis, but age, remaining growth, as Sukin mentioned, is important. Curve magnitude, anytime you get into that 70-degree range, you're certainly talking about that, and there's certainly nuances to that depending on the diagnosis. Sitting imbalance, and worry about these comorbidities, and we'll talk about those in a second. Well, why surgery in CP? And I think the data is becoming much more clear today that oftentimes patients will get excellent outcomes, not only radiographically, but in their improvement. This latest article from the HARM study group a couple of years ago really demonstrated how important surgery has been to many of these patients. When you ask the caregivers, they're very, very happy even 5 years after surgery. So it's important. Well, nutrition, again, you have to assess that. Get your colleagues involved, GI colleagues, your anesthesia colleagues. Blood loss expectations is really important. Infection, baclofen pump, really understand baclofen pump, whether they have one, what you're going to plan to do at the time of surgery, and then looking at VP shunt and any malfunction. So surgical site action for neuromuscular scoliosis is a big deal. This is a 30-year experience at our institution, published 6 years ago, and the overall infection rate was 10%. So 1 in 10 children get a major infection if they have spine deformity surgery, if they're neuromuscular scoliosis. That's double if you have spina bifida. And so these are data that are really sobering. We've improved over time, and these are the improvements that have happened with really simple, straightforward things. CHG wipes before surgery 3 to 4. We use ChloraPrep. We cover gram negatives. We use antibiotics in the bone graft. We use incisional wound vacs just to protect the incision and make sure it stays clean and dry in these children who are often incontinent bowel and bladder, and we always use drains. And so we've cut our infection rate essentially in half, and that's been a very successful project that over the years has worked very well. Gram negatives, you have to cover gram negatives. You have to redose the antibiotics. Really simple things go a long, long way. So give antibiotics within 30 minutes or an hour within surgery and dose it during the surgery to make sure you can avoid infection. Medical optimization is really critical. And so we at our place have this NSP clinic, which is our neuromuscular spine preoperative clinic. And it has a whole host of folks that really are great at what they do, including our anesthesiologists, pulmonologists, developmental pediatricians, et cetera. So it's really critical. And everybody has a voice as to how that patient is going to do with surgery and if they will move forward with surgery. And there's oftentimes that they say this patient is just too sick and we're going to have to tune them up, or we can't do the surgery because it's too challenging. That doesn't happen too often. So what are the general principles? The goals of surgery for neuromuscular are to balance the chest over the pelvis. The Cobb number is not that important. It doesn't matter what the Cobb number is. If you get the pelvis and the chest lined up, you're doing well. If you level the pelvis, those patients will do well. Obtain a solid arthrodesis. We oftentimes get enamored with the number of screws in the spine, but it's really getting good entry. Also, strategic implant density is important, and avoid or limiting complications. I sort of view it as not trying to win, but trying not to lose. In the neuromuscular spine, you're trying not to lose, so avoid complications. So just very quickly, some of the technical things in terms of pelvic fixation. We've been through a lot through pelvic fixation through the years. This is a nice biomechanical study showing you have to have really long screws that get past this sort of mid-axis point, which is really important. We've used Galveston technique. This is an old unit rod that was used many years ago, probably not used very often today, but very, very good at obtaining pelvic balance as well as getting the trunk over the pelvis. The Dunn-McCarthy technique is an S-rod, which actually works fairly well for Duchenne's muscular dystrophy for those patients who have a little bit of a lumbar kyphosis. Very easy to use, goes over the sacral ala. You have to create a soft tissue path that they can go. It goes very, very quickly, very easily, and provides some stability, especially when there's significant pelvic obliquity. The Dunn-McCarthy technique is oftentimes, again, used in Duchenne's patients. Here's a patient from years ago, and then a more modern sort of screw fixation technique. And we oftentimes operate on smaller curves in Duchenne's. Iliac screws are used and continue to be used today. The downside of iliac screws is you need a cross connector. They're oftentimes prominent, and so we try not to use those, at least at our institution, very often. But this is a patient that I operated on several years ago. We used a cross-link, which I don't often use today. Use these iliac screws with a cross connector to the rod. The sacral alar screws, which were developed by Paul Sponsauer and his colleagues, is really the mainstay, I think, of most institutions. We certainly use. It's relatively easy to place. Paul's got nice publication on how to place them. They're biomechanically strong. They're in line with your other screws. They're very low profile, and you don't need a cross connector, and they're very nicely done. There's a little video to the right that will show this quickly, so it's hard to see, but this is how it's placed. You can see that teardrop view, double checking it on the left and then on the right. Sorry, the video is very quick, but you can place these very nicely. This is a patient with cerebral palsy that we used them on and had a nice correction. They're very straightforward. You don't need navigation. You can place these using freehand and a little fluoroscopy. Here's a larger patient with a larger curve, correction of their pelvic obliquity. What about stopping at L5? Can you stop at L5? The indications today are very, very low. I think maybe indicated in the marginal ambulator. The advantages are really minimal today, and I think it's very uncommon for us to stop at L5, and problems can happen. Here's a patient of mine. We tried to stop at L5 because she's sort of a household ambulator, or exercise ambulator is more accurate. We tried to stop at L5, successfully stopped at L5, but these are intra-op photos and immediately post-op radiographs. She got loose at the bottom, had pain. You can see she has kyphotic issues even within the implant instrumentation. And so we had to extend her down into the pelvis, and she's done very well since that time. And she continues to ambulate, but not as well as she used to ambulate. What about circumferential fusion? Do you need circumferential fusion today? And the answer is very, very uncommonly. I think a few indications with very, very severe curves in which their lumbar lordosis is significant. Here's a patient of mine, normal intelligence, very severe curve with severe pelvic obliquity lumbar lordosis. So we went anteriorly, and we actually instrumented him anteriorly, got nice coronal plane correction, and then went posteriorly on the same day. and just the late instrumentation, much easier operation posteriorly. Getting down to the lordotic spine was easy. He actually had a back pump placed later on those images. Intraoperative traction is very, very useful in these patients for a lot of spine deformity, but including neuromuscular deformity. I use skin traction on the pelvis, asymmetrically apply it here on the right side with this high pelvis on the right side. Just hang weights over the edge. And then proximally, oftentimes we'll use Mayfield tongs, which works very well. They have a halo, place that. And then again, hang weight over the top. And you can hang significant weight and get pelvis really nice and level. You don't need little traction pins. You can't place it on the legs because they have hip flexion contractures often. It's very difficult. This works very, very well. Benzo in on the skin, use skin tapes, and it works very well, very safe. Just a couple points about a couple of diagnoses. So diffuse muscular dystrophy, the landscape has changed basically because of steroids. It's less likely they'll need spine surgery. When it's indicated, oftentimes these patients are larger because of the steroids and they're eating. They have larger curves. You have to be careful about malignant hyperthermia or a pseudo-malignant hyperthermia in these patients. We operate early because it correlates to their pulmonary and their cardiac status. Go T2 to the pelvis. You have to warn families because they have upper extremity weakness. Now their chest is taller and it's very difficult to get their hands to their mouth. And that's something you have to warn families because that expectation has to be there before surgery. Myelodysplasia, no posterior elements, so always requires an anterior fusion. Kyphectomy is a good operation when sitting, skin, and GI symptoms happen. Infection rate is very high in myelodysplasia, as we showed earlier. Spinal muscular atrophy, again, the landscape has changed basically because of medical improvements. So Spinraza came on the market in 2016 and really has changed how SMA is handled today, but you have to manage that yourself because if you're going to operate on these patients, you have to leave a window through a defined splenectomy site or a port with a catheter, which is what we're using today. So here's a patient of mine, 9+3, who had very significant curve. The nice thing about SMA is they're relatively flexible, even if they have large curves. So we did a posterior spinal fusion and instrumentation. And just importantly, we left a port for her to get her medication. So through the neurosurgeons, they came in and placed an intrathecal port, a line that then came under subcutaneously. And then there's this reservoir that goes under the skin that's easily accessible by the neurology team who then gives their Spinraza on their normal dosing cycle. So miscellaneous thoughts, know yourself and the team. These are big surgeries. It's physically and mentally demanding. It's a person job. And so if you need another staff or you need help, it's not a sign of weakness, but a sign of wisdom. Technically good surgery is important. Blood loss, we didn't really talk much about that. You need good technique. Tranexamic acid is definitely necessary. Replacement CC for CC blood at our institution. The anesthesiologists start running blood almost immediately after the surgery is started, CC for CC, so they don't get into DIC. Post-operatively, you have to be very, very careful, and there's a lot of things that have to happen. These patients get back to the normal state. We extubate all of our patients. They go on BiPAP. We limit transfusions when possible to avoid infection. And again, we keep dressings on, which are impervious for 2 to 3 weeks. So in summary, neuromuscular scoliosis, it's different than idiopathic, very challenging group. Indications are challenging. Technical aspects can be challenging, and the complication rates can also be challenging. So try to avoid complications. Generally, fuse T2 to the pelvis. And overall, I think it's a positive effect for patients when the indications are correct, when the patient and the family caregivers understand the expectations. Outcomes are generally good and a positive change for the patient. Thank you.
Great. Thank you, Dan. I want to thank all of our speakers, especially on this holiday weekend, for giving of themselves and their time and their expertise and wisdom. I think that was a wonderful hour of knowledge, and I hope everyone can enjoy the rest of the holiday weekend and see you soon. Take care, everyone.
Thanks.
Thanks, Josh.
Another weekend.
Bye, everybody. Enjoy.
See you guys.
Yes, thanks. Thanks, everybody. Great job.
Thanks, Josh. Bye, guys.